My talk on the veins will be much simpler for you, so I can cut it a bit. Because most of the problems you will have associated with the isomerism, so most of the condition I will be covering were already in part at least covered by Rabi. First of all, about the technique that you can use to assess the venous returns, both systemic and pulmonary. You may use 2D grayscale, you may use color Doppler, or you may use the most sensitive HD flow or sensitive bidirectional, unidirectional Powell Doppler. If you move to 4D, the two renderings that you should use are either the glass body mode you see here in comparison with the same slice 2D and a thick slice with 4D, and you see how many more pulmonary veins and arteries can be seen with the thicker slice in comparison with a single slice here, or the wonderful B-flow imaging, because it's a very high frame rate and it will depict the whole of the veins, and I will show you some very nice images regarding this type of approach. If you're going to use the glass body, please, especially if you consider the pulmonary veins, you need to use a bidirectional map, because since in the lung the arteries in the veins are very close one to the other, if you use with the same volume unidirectional blood flow, you will not be able to tell which is what, which is an artery and which is a vein. You see here, from the right lung, the veins will come down, so will be blue. All the blue ones will be veins, and all the red ones will be arteries. Okay, so this is why you need bidirectional map to study the pulmonary venous circulation. If you want to look at 2D anatomy on grayscale ultrasound, of course we cannot encompass the whole of the 4 pulmonary veins entering into the left atrium. So what we do is just cut a slice across the fetal thorax and either go for the lower ones or go for the upper ones. And the corresponding image is this one, an apical for chamber view, and you should see these 2 tags here, representing 2 of the 4 pulmonary veins entering into the posterior wall of the left atrium, and you see that the posterior wall of the left atrium is very close to the descending aorta. If you move to color Doppler, always on 2D imaging, you should reduce the PRF, otherwise you will not be able to see the venous low velocities of the typical of venous or pulmonary veins, and you see opposite direction, of course, because the ones from the lower lung will go up, and vice versa for the upper lung, no matter which is what, left or right. And of course, if you use even lower priority for grayscale onto color Doppler, it will show through, and you will see the whole of the pulmonary circulation across. If you use, bless you, if you use 3D and 4D technology, again, you may use the same conventional approach, so you will still rely on the basic for chamber view. The only thing is that you use a much thicker slice to encompass as many veins and arteries as possible, as you see here, or you may cut a very small slice like that one and use whatever color you want to confirm that at least 2 pulmonary veins are entering the posterior wall of the left atrium. If you use very thick slice encompassing the whole of the lungs, you will see a very blurred image, but virtually you will be able to see with this apical approach all the 4 pulmonary veins, one on the top of the others, entering somewhere in the back, in the posterior wall of the left atrium. But I would not recommend this type of approach, because with this approach you will see most of the peripheral branches, but you will not be able to confirm that they are indeed entering the left atrium, as you may tell from this image here. Or, and this is one of the assets of using a volume rather than a 2D approach, with a volume you can reconstruct virtual planes, and again either subtract, for example, the grayscale image and have only the angiographic components of the pulmonary veins, or you may also use a coronal approach, such as this MRI angio, and you can reconstruct it both with glass body and you see 1, 2, 3, and 4 with different colors, of course, because lower ones are going up and the upper ones are going down. The 4 pulmonary veins entering the posterior wall of the left atrium, and the same with the B-flow, 1, 2, 3, and 4 pulmonary veins entering the left atrium. This is the normal appearance. If you are very lucky, I was just playing with my computer during a very interesting meeting, sitting on a table, and I bumped into this image. And I could not had it anymore in the future, but I was lucky to get the 4 entrances of the 4 pulmonary veins in the posterior wall of the left atrium, and this is the corresponding clip. And you see here barely visible the posterior part of the interventricular septum, part of the interventricular plane, and the 4 orifices actually where the left atrium should be. If we move to the abnormality of the pulmonary venous return, these are the 3 subtypes with the infradiaphragmatic and supradiaphragmatic types sharing a vertical vein, which either goes towards the innominate vein or to the superior vena cava, or going backwards behind the heart, below the diaphragm, and this is usually obstructed into the portal circulation or the inferior vena cava. Whereas the much rarer intracardiac variant either goes into the coronary sinus or directly into the posterior wall of the right atrium. And you see here 2 drawings explain to you from the posterior aspect of the heart what is the vertical vein where the 4 pulmonary veins meet, and then going up or down according to the subtypes of abnormal pulmonary venous return. So where to look with cranial ultrasound if you have a doubt, if you want to rule out such an abnormality? Of course, on the 4-chamber view, this is the conventional view that you should aim at while you're doing your screening. And you may have 2 suspicious views highlighting the possible presence of an abnormal pulmonary venous return. Oh, sorry. Either you have no pulmonary venous at all. Of course, in both these hearts are abnormals and there are isomerism. Of course, right heart isomerism. In this case, there was no vein visible in the posterior wall of the left atrium. Or you may see the vein, and you may also see, you do not see the vein, but you see this type of cross-sectional area. This is the vertical vein I showed you before, cutting cross-section. So whenever you see this type of a round structure here behind the heart, be sure that it's not disappearing, otherwise it's just the esophagus with a bolus of amniotic fluid swallowed by the baby. But if it remains there, it's in favor of a vertical vein going up or down, and then you should chase it with a and this is where the vertical vein will go either orthotopic venous return from the left lung, but there is the orthotopic venous return from the left lung, but there is no vein coming back to the posterior wall of the left atrium from the right lung. This is abnormal because with a thick slice you should be able to see such a vein entering the posterior wall of the left atrium. And then I turned longitudinally, and longitudinally with color Doppler I was able to see I'm in front of the heart. This is the inferior vena cava. This is the suprahepatic veins here and the ductus venosus. And you see here, this is the abnormal pulmonary venous return connecting with the inferior vena cava, which is even more clearer with B-flow. You see here, this is the scimitar vein and this is the scimitar vein. These are suprahepatic veins. This is the inferior vena cava, and this is coming down from the lung behind the heart and meeting the inferior vena cava here. But the unusual appearance here is that the degree of hypoplasia of the right lung is not so pronounced. So if you are not very careful, you will not be able to get the mesocardia. You may overlook these conditions. If you use for stick, there is a very nice paper published some 4 or 5 years ago by Paolo Volpe, which is a close friend of mine in Italy. He has published also on the use of B-flow on the aortic arch abnormalities. But you see here how nicely the vertical vein is depicted with this technology, meeting the innominate vein here, consistent with this type of drawing here. And also in the different infradiaphragmatic type, you see the vertical vein here. And this is another case similar to the scimitar, but on the left side we diagnosed recently using the same type of technology. This is the descending aorta, and behind it you see pulmonary veins here, inferior vena cava, and lower left pulmonary vein meeting at this level. So this is a way to improve the accuracy of diagnosis of this type of technology. A brief rush on the abnormalities of the systemic returns, because these were covered very fully by Rabi in his talk on isomeric syndromes. Just an anatomic reminder on where these veins are, and considering the anatomy of the normal azygos veins, which is usually always there. The only difference with the azygos continuation is that in this case, the normal azygos vein will start at the lower thoracic level, whereas the continuation will include the lumbar level. If you want to have a look at the inferior vena cava, you can use the longitudinal view or cut cross-section views at the level of the 3 vessel, and the 3rd vessel being the superior vena cava, or at the level of the abdomen with the classic position that Rabi showed you. As far as the azygos continuation is concerned, again you can use the 3 vessel view, with the 3rd arch being the other way around, because the blood is going from the azygos, which is quite close to the aorta, towards the superior vena cava, so it's the blood goes from back to anterior, or longitudinally with this type of approach, and you see here the azygos and the azygos arch meeting at the level of the draining into the superior vena cava. And this is the innominate artery on the top of that, the innominate vein, sorry, on the top of that. Again, with B-flow, you have a whole and thorough idea of the whole of the venous system here: superior and inferior vena cava, suprahepatic veins, and ductus venosus. Just a few hints, and then I will finish, just for the sake of time, of the coronary sinus. This is the structures you see here. This is the normal size of the coronary sinus, which receives blood only from the coronary circulation. And it can be seen behind and below the heart, such as this very tiny structure here, both with the lateral approach and with an apical approach. This is the normal size of the coronary sinus, just below the heart, on the posterior wall of the heart, in the groove between atria and ventricles. So as a consequence, on the normal four-chamber view, which is a bit up in the thorax, you will not have any hint of the coronary sinus unless it is dilated for one or more reasons, such as this one. In that case, it will be cut in cross-section and will appear here in the left atrium between the mitral valve and the wall of the left atrium. The size of the coronary sinus will depend on the anatomy of the systemic venous return. What occurs is this one. The persistence of the left superior vena cava will dilate the coronary sinus, and this will appear as a thickened vessels at this level. And if you cut across the four-chamber view, cut at this level, so we'll get the cross-section. If you cut the three-vessel view, you will cut at this level, and you will have the fourth vessels on the right of the pulmonary, on the left of the pulmonary artery. So you will have the two vena cava here the right-sided one and left-sided one. The size of the coronary sinus will depend, as I was telling you before, on what is the arrangement of the venous returns. Bear in mind that whenever you see a persistent left superior vena cava, there is an increased risk of association with aortic coarctation, so follow up these cases in the second half of pregnancy. If the situation is that the two vena cava are present at the same time, so you will have a very tiny coronary sinus. If the left-sided one will remain and the right-sided one will regress, and you see here, you will have the left superior sided one patent and no right superior vena cava, then you will have a larger coronary sinus because it will collect the whole of the blood other than the inferior vena cava, the other vena cava. Or you may have very unusual conditions, such as this one, in which you have a very huge coronary sinus, because in this case it was both a left superior vena cava persisting and an azygos continuation, and both were draining into the poor coronary sinus. Okay, and this is why it's so dilated. And if you cut across longitudinally, in case of absence of inferior vena cava, you have the images that Rabbi showed you with the azygos continuation here and absence of the inferior vena cava, but I will skip this because this was already covered. And also this one. Okay, so in conclusion, systemic and pulmonary venous returns can be studied by 2D and 4D technology with great accuracy. The assessment of the sequential anatomy, starting with the venous returns, is of most importance to detect and confirm cardiosplenic syndromes and total abdominal pulmonary venous return, and for the technology, and especially glass body with HD flow, which is very sensitive to very low velocity flows, and sorry, B-flow technology are less time consuming, will increase the confidence in reaching the such difficult diagnosis such as abnormal pulmonary venous return. And thank you for your attention.